Greetings. Today we are going to talk about dental management for hypertensive patients. If we talked about hypertension regarding systolic blood pressure and diastolic blood pressure, the two values that are used to measure the blood pressure. The systolic blood pressure for a hypertensive patient should exceed 140 mm mercury, and diastolic blood pressure will exceed 90 mm mercury. There are two stages of hypertension, stage 1, which is of unknown cause, and stage 2 of known cause. The mild form or less severe form, mild or moderate form for hypertension is stage 1 hypertension. And it needs, if the patient reaches stage 1 hypertension, so this means that the patient needs treatment. The secondary hypertension is the most severe form, and this means that the patient needs emergency treatment. Because the patient's systolic blood pressure for stage 2 hypertension, it exceeds 160 mm mercury, and its diastolic blood pressure will exceed 100 mm mercury. So that's why we said that for stage 2 hypertension, this patient needs medical emergency treatment immediately. This was an overall outline for hypertension or introduction for hypertension. Before we explain the dental aspect or dental consideration for a hypertensive patient. These hypertensive patients, they suffer from a lot of oral manifestations. If you see some of these oral manifestations and this patient mentioned hypertension history in his medical history, mentioned that there is hypertension in his medical history, so this means you're going to find these oral manifestations or the cause of these oral manifestations will be due to a systemic cause, which is hypertension. So the treatment is by treating the underlying systemic cause and not only by topical treatments. And these oral manifestations are not of a local cause, they are of systemic cause. What are these oral manifestations for hypertension? First is xerostomia. Xerostomia is caused by antihypertensive drugs, including angiotensin converting enzyme inhibitors and diuretics. This xerostomia in general, whatever the cause was for xerostomia causes tooth decay and causes difficulty in chewing and swallowing due to the reduced lubrication of oral cavity and reduced self-cleansing in the oral cavity, reduced salivary flow rate, which is below 0.1 milli per minute. This reduced salivary flow rate causes increased caries risk, and this reduced salivary flow rate also causes reduced lubrication of the oral cavity, which causes difficulty in chewing and swallowing. Also, it may cause, this xerostomia can cause candidiasis, candida infection of the oral cavity, and cause burning mouth syndrome. A burning sensation in the oral cavity in different areas, including the palate, the tongue, the buccal mucosa, burning, tingling sensation in the oral cavity, usually caused of systemic cause, and here is caused by xerostomia. The main cause of burning mouth syndrome is xerostomia, and xerostomia has different causes, maybe medication induced or condition induced. Here it's medication induced caused by antihypertensive drugs. There are also some taste disturbances that this patient may suffer from, including two conditions: the dysgeusia, which is altered taste sensation, or this taste disturbance. Taste disturbance, which means the patient complains of that he can taste salty foods, for example, but he cannot taste sugary foods and beverages. He cannot feel any taste sensation for sugary foods and beverages. So this means that this condition, it's called this altered taste sensation or taste disturbance, is called dysgeusia. Dysgeusia is caused by antihypertensive drugs. It's a side effect of antihypertensive drugs. This patient also may complain of absence of taste sensation or loss of taste sensation. Complete loss of taste sensation, this patient cannot feel any taste sensation for all foods and beverages. So this condition is called ageusia, which means absence of taste sensation, complete absence of taste sensation or loss of taste sensation. What can we do for this patient suffering from xerostomia? or as a consequence to this xerostomia, he is suffering from candidal infection, suffering from halitosis, suffering from tooth decay, suffering from difficulty in chewing and swallowing, suffering from burning mouth syndrome, okay, suffering from dysgeusia and ageusia, suffering from many consequences from this xerostomia. So we should know the cause to treat the cause, okay? We are not treating the overlying signs and symptoms, we are treating the cause, okay? Treating the xerostomia is by 2 drugs, okay? They are called salivary substitutes. Salivary substitutes is explained in detail, okay? It will be explained in a video. In the following videos, just follow us and subscribe our channel, and you will receive notification for this video soon, okay? These 2 salivary substitutes, we're going to mention them briefly now, okay? These 2 drugs are called pilocarpine and cevimeline. They are 2 systemic drugs used as salivary substitutes to treat xerostomia or hyposalivation. Some lifestyle protocol instructions should be given to this patient. Firstly is to drink water frequently and ingest sugarless candies, okay, to induce, because during chewing there is a stimulation of salivary production, of saliva production. So chewing sugarless candies every now and then or frequently will stimulate the saliva production. Also instruct this patient or inform this patient to stop coffee consumption. Reduce coffee consumption because caffeine reduces the salivary flow rate, okay? Usually after coffee you need to drink a lot of water because caffeine reduces the saliva flow rate and reduces saliva production. So you should reduce coffee consumption. You should instruct the patient or tell the patient to reduce any coffee consumption and avoid the alcohol with mouthwashes, okay? Avoid prescription of any alcohol, any mouthwashes containing alcohol like menthol, okay? And prescribe topical fluoride gels for this patient to reduce this high caries risk. Second oral manifestation is gingival hyperplasia. Gingival hyperplasia is caused by calcium channel blockers. The patient comes complaining of gingival enlargement, and you didn't find any local cause in the oral cavity. There is no plaque accumulation, there is no food impactions, there is no periodontal pockets, there is nothing, okay? Nothing, there is no an oral local cause that may cause this gingival enlargement. So you start to suspect you didn't know the cause because you didn't know a good medical background that gives you a hint that this hypertension may cause, as an oral manifestation, it may cause gingival hyperplasia. This hypertensive patient will suffer from gingival hyperplasia due to the calcium channel blockers, an anti-hypertensive agent which is called the calcium channel blockers, including the nifadipine. So what's the treatment for this gingival hyperplasia induced by antihypertensive drug? Is to change the drug or stop it, okay? So you will tell the patient that this gingival hyperplasia is due to your antihypertensive drug. If this antihypertensive drug is calcium channel blocker or nifadipine, okay, it's one of the examples of calcium channel blockers, okay? For example, nifadipine, it's just an example, but here we include all the calcium channel blockers that they cause gingival hyperplasia. So you will tell the patient that this gingival hyperplasia is not of a local cause, you don't have any dental cause, it's a non-dental cause, it's a systemic cause due to the antihypertensive drug. So when your condition regarding hypertension becomes better and you start to stop this drug or reduce the dose for this drug, or if you change this drug completely and find another alternative or substitute, this gingival hyperplasia will be relieved, okay? Because you're going to give this patient topical treatments and the cause will remain as it is. The oral manifestation will remain as it is because this oral manifestation is of a systemic cause, not of a local cause. So even if you prescribed topical treatments, it will not be effective, okay? The third order manifestation is lichen node reaction. Lichen node reaction is a derivative of the lichen planus, and lichen planus is an autoimmune disease. Okay, this autoimmune disease, the lichen planus, is including the whole body, the skin and the mucous membrane of the whole body, but lichen node reaction is only restricted to the oral cavity, including an erythematous lesion which is covered by white plaque coating, okay, and usually in the buccal mucosa. It's caused by antihypertensive drugs as captopril, furosemide, spironolactone, labetalol, okay, and the mild form for lichen planus is the lichen node reaction because it's restricted to the oral cavity, but lichen planus is more severe autoimmune disease. Treatment for this lichen node reaction, which means the lichen node reaction is reversible, but the lichen planus is irreversible. Okay, so this lichen node reaction should be treated as soon as possible, okay, to avoid its development to a more serious condition that may cause lichen planus. Okay, so for lichen node reaction especially, you're going to prescribe a topical treatment, which is topical corticosteroids, and you're going to inform the patient that he should change his antihypertensive drug or stop it to relieve this lichen node reaction. So this lichen node reaction should be treated as immediately as possible. Okay, you should prescribe topical corticosteroid, and we're going to mention a whole chapter for the topical corticosteroid, and this patient should change his antihypertensive drug or stop it. There are some drugs that we prescribe or use in dentistry that interact with antihypertensive agents. Three main drugs that interact with antihypertensive agents, including the local anesthetic agent, the epinephrine, and non-steroidal anti-inflammatory drugs. For the non-steroidal anti-inflammatory drugs, avoid prescription of non-steroidal anti-inflammatory drugs, especially for long-term to patients with hypertension. And instead, you can prescribe paracetamol. Okay, paracetamol, Tylenol. It will be much better for a hypertensive patient than prescribing non-steroidal anti-inflammatory drugs. Okay, because non-steroidal anti-inflammatory drugs, we said before that their mechanism of action depends on what? On antiplatelet activity, increasing the bleeding risk. Okay, and we should avoid any high bleeding risk, any stress, any anxiety for the hypertensive patient. Okay, and because these non-steroidal anti-inflammatory drugs, they interact with the antihypertensive drugs, causing reduced effect of these antihypertensive drugs. Okay, and this may suspect the patient to be in a medical emergency case. Okay, including increase in blood pressure, including increase in cardiac output, including stroke, including cardiac arrest. Okay, so you should tell the patient if it's urgently, prescribed, that this non-steroidal anti-inflammatory drugs is urgently prescribed and the paracetamol is not effective, you should tell the patient not to take the non-steroidal anti-inflammatory drugs with his antihypertensive drug. You should leave a time interval between the two drugs, an enough time interval, okay? Not less than 4 hours or 6 hours between the two drugs to avoid the drug interaction between both of them. The second drug interaction is between the beta blockers, antihypertensive drugs, and epinephrine. You should mind that epinephrine is used in two procedures in dentistry, okay? In local anesthetic induction, agent induction, and in retraction cord for crown and bridges dental procedures. We should completely avoid the retraction cords impregnated with hemostatic agents in crowns and bridges for hypertensive patients, because they have a very high amount of epinephrine, double the amount present in the local anesthetic agent. Okay, so avoid completely using impregnated retraction cord, okay, which is called the chemical retraction cord, which contains a hemostatic agent. Instead, use a retraction cord which is non-impregnated, which doesn't contain a hemostatic agent. Okay, for local anesthetic injection, sometimes we need to inject local anesthetic agent with epinephrine. Why? Because we should reduce the stress and anxiety for a hypertensive patient. Okay, and this will not happen unless we use a local anesthetic agent with epinephrine, containing epinephrine, even in very minute or small doses. Okay, because this epinephrine, it reduces bleeding and increases the duration of the local anesthetic agent, producing a profound local anesthesia to reduce the sense of pain for this patient during the dental procedure, so reduce the fear and anxiety for this pain during the dental procedure. In mind that you shouldn't let your patient feel any sense of pain or fear or anxiety during the dental procedure. Okay? So, if you use this local anesthetic agent with epinephrine, it will be the first injection only, and you're going to inject half of the carpool, very small doses, and you're going to inject it very slowly, and you're going to check for aspiration to avoid the insertion of the local anesthetic syringe, the needle of the syringe into a blood vessel, okay, to avoid its insertion into a blood vessel, to avoid the absorption of epinephrine by the blood, and you're going to inject it slowly, inject the local anesthetic agent slowly to avoid rapid absorption of this local anesthetic agent which contains epinephrine, to avoid its rapid absorption by the blood. Okay, so to avoid the absorption of epinephrine by the blood, you should do two steps. You should inject it slowly, and you should avoid its insertion into a blood vessel by the aspiration test. Okay. You should tell the patient not to take a beta blocker before injection of local anesthetic or before a dental procedure in general, because usually beta blockers, they interact with local anesthetic agents and especially with epinephrine. Okay, so you should tell the patient not to avoid taking any beta blockers before the dental procedure, because these beta blockers will increase the local anesthetic toxicity. Okay, so you should increase the dose interval, or the time interval between the two drugs, the local anesthetic agent and the beta blockers. What else? We're going to talk more about the epinephrine for hypertensive patients. You should know that the maximum dose of epinephrine in patients with cardiac risk is 0.04 milligram. The amount of epinephrine present in retraction cord which is impregnated by hemostatic agents exceeds this amount, so they are completely contraindicated for those patients. Mind that during the dental procedure you should avoid any stress or anxiety or pain for this patient. And you should measure the blood pressure for this patient with a history of hypertension before the dental procedure. If it's above 140 mm mercury systolic blood pressure or above 90 mm mercury diastolic blood pressure, you should tell the patient to take his anti-hypertensive drug and no dental procedure to be done on that day, okay, until his blood pressure is adjusted. Okay, for this condition especially, you should avoid, if it's an emergency dental procedure, you should avoid the injection of any local anesthesia containing vasoconstrictor and avoid using retraction cords with epinephrine, okay, especially in patients with cardiac problems. Okay, there are patients with primary hypertension which are not of cardiac problems, and there are patients of secondary hypertension which are more risky, okay, and they have cardiac problems as arrhythmia, as myocardial infarction, as stroke, okay, as congestive heart failure. What's the difference between stroke and myocardial infarction? Myocardial infarction is the reduced blood flow to the heart, which causes this heart muscle to be of less functioning, okay, or to cause the dysfunctioning of this heart muscle, causing heart death. For stroke, it's really much more related to the brain. It's reduced blood supply to the brain, maybe due to an internal hemorrhage, okay, it's of a hemorrhagic cause, or due to ischemia, which means by reduced blood supply to the brain, so there's reduced oxygen supply to the brain, and this causes the death of brain cells, whether it's of an ischemic cause or hemorrhagic cause, and this will cause stroke. Death of brain cells, which means stroke. Okay? If this patient was suspected to stroke, subjected to stroke for less than 6 months, or suffering from myocardial infarction, or suffering from congestive heart failure, or had done any previous operation in the heart, you should avoid any local anesthetic agent with epinephrine, containing epinephrine, and avoid using retraction cords containing epinephrine, and you should measure the blood pressure before any dental procedure. And avoid any pain or fear or anxiety for this patient. To avoid pain, you should inject local anesthesia with epinephrine. So you're going to wait not to carry out the dental procedure on the same visit. You're going to wait till the blood pressure for this patient is adjusted, okay, and becomes near to the normal range. And tell this patient not to take a beta blocker before the dental appointment, okay, to avoid its interaction with the local anesthesia and with epinephrine. Okay, there's a slight important note that you should mind measuring blood pressure for pregnant women, for diabetic patients, and for the elderly, okay? And there are other diseases that can be treated with antihypertensive drugs also. For the part of drug interactions, there are other diseases that can be treated with antihypertensive drugs, like patients having headaches, regional pain, renal failure, glaucoma, congestive heart failure. They may take antihypertensive drugs. So you should take care of your local anesthesia, of your epinephrine, of your non-steroidal anti-inflammatory drugs prescription for these patients, because you should ask them if they are taking antihypertensive drugs or not, because these 3 agents used in dental practice, the local anesthetic agent, the non-steroidal anti-inflammatory drugs, and the epinephrine, they will interact with these antihypertensive agents, causing what we have mentioned before. Okay, you should measure the blood pressure, especially for longer sessions of restorative treatment, before implant placement, and before periodontal surgeries. This was all about hypertension, okay? Hoping that this video is useful enough, and if you want more videos and you are interested in the videos for dentistry and beyond, just subscribe our channel and you're going to receive notifications of our following videos. Thanks for listening and watching. Thank you.